It is now my pleasure to introduce today's lecturers, Dr. Tierney and Dr. Medea Gegia. Dr. Tierney earned his medical degree from Virginia Commonwealth University and a master's in public health degree from the University of California, Berkeley. He completed an internal medicine residency and infectious disease fellowship training at Massachusetts General Hospital. Dr. Tierney has worked on the prevention and treatment of HIV and tuberculosis infection in settings of socioeconomic disparities since 1999. Dr. Medea Gegia has been working in the TB field in Georgia since 2002. She received her MSc in clinical research from Emory University in 2011. Dr. Gegia has experience in working with MDR and XDR-TB patients. She has also led 2 consecutive TB Global Fund projects at subrecipient level in addition to scientific activities. Since 2010, Dr. Gegia is a member of Childhood Task Force Group in the European region. Currently, she works as the clinical advisor for the USAID TB Prevention Project in Georgia. And if technology allows, Dr. Jennifer Furing will also join us slightly later as a moderator of this webinar. As of
Hello, everybody. This is Dylan Tierney. Nice to be with you all this morning. So today we're going to be talking about pediatric DR-TB meningitis. I think it's an important topic because it is such a devastating disease, and pediatric DR-TB in general is I think relatively, what's the right word? Not ignored, but I think we need to know more about DR-TB in children. It has been I think it's taken a backseat to the management of adult patients, but these pediatric patients are fragile, and we want to do a good job in managing them. So today we're going to be focusing on 3 major learning points. First of all, we're going to talk about the diagnosis of DR-TB meningitis in children. We're also going to discuss strategies to manage the complications of DR-TB meningitis and reduce mortality in children. And then we're going to talk a little bit about anti-TB drug regimen selection and empiric therapy in pediatric DR-TB meningitis. So I want to say just in general that a lot of the points that we're going to be making here are they're many times general points about the management of TB meningitis. There is not a lot of data for the management of DR-TB meningitis, and in particular DR-TB meningitis in children. So I will try to point out, or we will try to point out as we move through, what is a general concept, and then what is backed specifically by data in pediatric drug-resistant TB meningitis. And I've already started using some of these acronyms, so just kind of throw them out there. I'm going to tuberculosis, TB, drug resistance I'll use as DR, multi-drug resistance I'll say MDR, and TB meningitis will be abbreviated as TBM. I encourage you to ask questions using the questions for Xpert box as we move through the talk. So I think a good place to start any talk like this is to try and understand the scope of the problem. The incidence of pediatric MDR-TB meningitis it just simply isn't studied. Even our understanding of MDR-TB in children hasn't been developed until recently in a paper by some colleagues at the Harvard School of Public Health. This recent paper estimated that more than 33,000 incident cases of childhood multi-drug resistant tuberculosis occur annually. And this paper really represented the first published approximation of the scope of drug-resistant disease in pediatric patients. And as an aside, it was a significant increase in the number estimated by the WHO. So from these numbers, we can start to extrapolate how many cases of MDR-TB meningitis there are in children. So using data from other studies, we know that as many as 1 to 3% of pediatric cases of MDR-TB present with meningitis. And that rate is probably even higher in HIV co-infection. And we also know that in adults, it's estimated that maybe even 10% of disease is CNS tuberculosis, and we also know that in children that CNS tuberculosis or central nervous system tuberculosis or TB meningitis occurs more frequently than in adults. So we may be talking about thousands of cases of pediatric DR-TB meningitis around the world. But few of these cases really end up getting reported because of lack of bacteriologic confirmation of disease. So I think the prevalence numbers, the incidence numbers, they don't really represent the intense suffering that's associated with disease. I mean, TB meningitis is a feared manifestation of tuberculosis. Most of the literature on outcomes comes from adults with TB meningitis, where somewhere between 15 to 40% of people die, and that's mostly in drug-susceptible disease, and that's despite effective treatment regimens. In children, the numbers are even worse. So we know from studies in the 1940s and 1950s that in untreated children, the condition is almost universally fatal. And the median time to death is somewhere around 3 weeks. Even for those children who are treated appropriately, TB meningitis is associated with high rates of mortality and morbidity, especially in children that present with advanced disease. And in those children who present with advanced disease, about 80% will develop neurologic sequelae. So we're talking about a really consequential manifestation of TB. And if we look at multi-drug resistance in TB meningitis in children, it appears that to confer an even greater risk of a poor outcome. So a group of investigators looked at all children from newborns to 13 years old admitted to Tygerberg Children's Hospital. It's this study here that I'm admitted to Tygerberg Children's Hospital in Cape Town, South Africa from January 2003 to April 2009. And they looked at either a diagnosis of confirmed TB meningitis or probable TB meningitis. And what they found was that MDR-TB was strongly associated with unfavorable outcomes and death, even after adjusted analysis, compared with even isoniazid monoresistance or rifampin monoresistance. So we see that with mortality rates in MDR-TB, the odds ratio was 63.9, which is a massive increase in mortality compared to drug susceptible or monoresistant disease. So one of the rare studies that has closely examined pediatric DR-TB meningitis is a retrospective review focusing on the clinical course of 8 children who had drug-resistant TBM in a TB hospital in Durban, South Africa. Investigators here reviewed the records of children who were, again, newborns to 13 years old, and they found 8 cases of MDR-TB meningitis between 1992 and 2003. And now this is really the only paper that that is in the literature that focuses exclusively on pediatric DR-TB meningitis. So in this paper, 6 of the 8 children had HIV co-infection, and 7 of the 8 children died of their disease. So that's a mortality of 87.5%. Their presentations, I think, were classic for DR-TB meningitis, or for pediatric TB meningitis in general. They were characterized by vague signs and symptoms such as diarrhea, vomiting, and fever. And then they had some more localized neurologic signs as the disease advanced. So even though the numbers were small, I think it's also important to note that there was a pretty significant delay in diagnosis, and that that delay in diagnosis correlated with delay to effective therapy and mortality. I should also point out that there were low rates of contact tracing and low rates of steroid use. So then, to recap, just in this introduction, we know that MDR-TB in children is underappreciated. And of all of the manifestations of pediatric MDR-TB, we can postulate that meningitis is the most lethal form of the disease. So now we have to try and we have to ask what we can do to improve outcomes. So the rest of the talk is going to be arranged around the review of some clinical cases of pediatric MDR-TB meningitis. And Dr. Gegia will present these cases, and then we'll use them as a foundation for discussion about specific management issues that are critical to improving outcomes.
Okay, good afternoon to everybody. Before actually moving to the clinical cases and discuss and highlight the key points, I'll briefly overview, I will give you a brief overview about the country of Georgia where from which the clinical cases are coming out. So this is this was a former Soviet Union, and since the early 90s is an independent country with a high incidence rate, which amounts 116 per 100,000. So it's still considered as one of the high MDR-TB burden countries. And the recent statistics shows that MDR-TB prevalence in the country is 11% among new cases, and 38%, almost 1/3 of cases were resistant among previously treated cases. So the country implemented MDR-TB program since 2008 and soon reach a universal access. Now I'm going to present 2 clinical cases from the Georgian setting, diagnosed with MDR-TB meningitis and treated through the National TB Program in Georgia. And here is a 9-year-old girl living in the country with a no post-medical history and BCG vaccinated at birth at the most of the children in this country. So she lived with her mother, who is well, but her father had an MDR-TB diagnosed in the same setting and treated in the hospital. So the patient developed fever, fatigue, and one of the most common symptoms of meningitis, persistent headache that was lasted over a 2-week period, which was the main reason why she was admitted to the hospital. And here is the basics of a physical and lab examination about the patient. And I wanted to point on some neurologic exams as delirious, photophobia, and a stiff neck as one of the most frequent and classical symptoms of meningitis. So, of course, her CSF was sent for the microscopy and culture, and we see that that smear was negative, and the result appeared simultaneously, but the culture appeared to be positive. And later on, since our culture was positive, drug susceptibility testing was done routinely, and it revealed resistance to INH, rifampin, streptomycin, ofloxacin, and an ethionamide. So literally we see that her profile was only sensitive to the injectables, and that is not very common in the country, but I just want to like highlight again that the case comes from the high MDR-TB burden countries. And here is something that I want to highlight, the few of them. The first is that in a real life, those who work especially in a ward and in a clinical settings, we know that now we can hardly see the cases, especially with DR-TB meningitis, where the culture is positive, and the patient could be treated based on their own DST profile. So in terms of this kind of a little bit like unusual and very interesting case that we had an option to treat and modify her treatment regimen based on a DST profile. And another thing that I want also give a brief overview is related to her DST profile. So it basically appeared like after 2 months, but it showed that this is fully matched with her father DST profile. In Georgian setting, we never did a specific study about that, but to barely compare, but to just, generally compare, it's only like 60% of cases where we see the exact, like match. So it's kind of was a situation where her father and a child, even though we took this into consideration as a close contact, had the same DST profile. But also like keep this in mind that while presenting that case, that those results appeared later, since we know that especially second-line drug susceptibility testing is done on a solid media, and it takes a few months before getting the final result. So therefore, the treatment regimen, initial treatment regimen that is presented in a slide, was designed empirically, and therefore it contains the first second-line drugs, at least 4 second-line drugs, including injectable, fluoroquinolone, cycloserine, protonamide, and PAS, and also pyrazinamide from the first line, but not counted as a key drug, and the 3 drugs that is available in the country, clarithromycin, amoxicillin, and clofazimine from so-called group 5. And this is like a very typical empirical treatment regimen for the most of DR-TB cases in Georgia. So even though the patient was on a proper and very extended treatment regimen and stayed at the hospital, she continued to complain of fatigue, and physical exam that was done repeatedly revealed persistent neurologic signs. So we can see some of them in the slide. And now here is a question to the audience. So what is the most likely cause of the patient's failure to improve despite MDR-TB treatment? And we see the answers A, B, C, or D. And yeah, so I agree. So the almost 100% of the participants answered that correctly, that indeed CNSF complication was definitely the case, the case of failure. And this is what actually happened with this patient. Again, to go back to the slide. So, because of that, that was nicely shown and repeated MRI exam that at month 2, so it revealed obstructive hydrocephalus, paraventricular swelling, and inflammation in the inner capsule. So we see that due to that, dexamethasone was subsequently started and added to decrease inflammation. But even though clinical condition did not improve and the patient developed seizure and vomiting, So the patient underwent placement of extraventricular drain. That was done by neurosurgery with a good result. So afterwards, seizure and headaches resolved, but the nausea and vomiting continued. So these symptoms we have felt should be due to pyrazinamide and pus, like nausea and vomiting, and that was subsequently stopped, and therefore regimen was modified. But before getting there, here is another question that is coming to the audience. How should medication be given to an obtuse patient with DR-TB meningitis? And this is like a very practical, sounds like very easy question, but it's very practical. And yes, exactly the correct answer is C, that administer all oral medication via nasogastric tube. But in some like very rare cases, but still there are some like situation when people think that it could be done intravenously, and then later on the patient could be switched to oral medication. But we know that in this case, the risk of developing and amplifying resistance is high, and therefore, so the correct is to administer all medication via tube. And later on, because of the side effect, the treatment regimen was modified, and we see that the patient was left on capreomycin, levocicloserine, and protonamide, and subsequently patient gained in weight and clinically did well. So that was the reason why he was discharged from the hospital, and she finished her treatment in an outpatient setting. So she treated for 12 months, and her treatment regimen was defined as a treatment completed. So I just want to mention again that even though this case was diagnosed earlier and therefore the treatment outcome was successful, we all know that DR-TB meningitis is very difficult to diagnose, and most frequently this delay in diagnosis leads to the poor treatment outcomes. So now I will talk over Dylan again, and he will highlight these issues. Dylan?
Thank you. So before I go further, I just wanted to answer a question that came up about the incidence of DR-TB meningitis. In children. So the paper that was recently published showed that there were 33,000 incident cases of MDR-TB in children, and we estimate that somewhere around 1 to 3% of pediatric cases present with meningitis. So the numbers that we're expecting, globally for pediatric DR-TB meningitis is somewhere around 1,000 to, a couple of thousand cases, something like that. Now to return back to the to the points to make after the case, I think it's important to note here that we're presenting these cases in a webinar about DR-TB meningitis in children. So you already know the correct diagnosis, but in the real world, in your clinics and in the wards, when you see the child, he or she is often going to have an illness with a constellation of non-specific signs and symptoms, mostly fever and lethargy, and these symptoms have likely been going on for weeks. And you may not even have been the first clinician to see the patient for the evaluation of these symptoms. So, you may consider infections of the central nervous system, which we've been referring to as the CNS, early on. But even if you do, there are still many causes of infectious meningitis that need to be entertained, including bacterial, viral, and fungal etiologies, in addition to MTB. So, and that's not even to mention the non-infectious causes of disease. So, the reality is that in low resource settings, the workup of all this broad differential is limited by poor access to diagnostic tests. And in high resource settings, the low prevalence of TB in general leads to low clinical suspicion. So as a result, many patients are treated with broad spectrum antibiotics until they deteriorate clinically, and then you have to adjust the differential diagnosis. So all of these factors, the nonspecific symptoms, the inconsistent serial medical evaluation, the broad differential diagnosis, the limited diagnostic capacity, the incorrect empiric therapy, and low clinical suspicion makes delays in diagnosis of TB meningitis in children very common. Children are particularly high risk for delayed diagnosis among all patients with TB meningitis. And here's the key point. Early diagnosis and treatment of TB meningitis has been shown in multiple studies to be the best predictors for survival. So the bottom line then is that it's critical for us to become better at the diagnosis of TB meningitis. All right, so there are questions that are coming up that I will answer as we, either through our talk or if they don't get answered through our talk, then I will answer them, or we'll answer them specifically at the end, or prior to our next case. So TB meningitis can occur as the sole manifestation of TB, or it can occur concurrently with pulmonary or extrapulmonary sites of infection. In children, in the early stages, TB meningitis is characterized, as I said, by nonspecific symptoms of poor health rather than classic signs of meningitis. So the early diagnosis really relies on astute clinicians to tie together these vague symptoms, poor weight gain, low-grade fever, listlessness, and consider TB meningitis as a possibility in order to request the appropriate tests and treatment. I think the point here is that we need to consider pediatric TBM as a subacute meningitic illness. We need to conceptualize early meningitis as this poor weight gain, low-grade fever, maybe some personality change. This prodrome can last for 2 or 3 weeks, and the classic symptoms of neck stiffness are usually absent in the initial stages of the disease. And it looks like drug resistance patterns don't affect the presentation. So our patient had fever, fatigue, persistent headache, which is consistent with this prodromal phase, but when they presented to the hospital, they had more advanced neurologic signs, suggesting that the disease had progressed to the meningitic phase, in which we see more pronounced neurologic features, such as meningismus, protracted headache, vomiting, lethargy, confusion, and varying degrees of cranial nerve signs. If untreated, this patient will progress to the paralytic phase with confusion, giving way to coma, seizures, hemiparesis. The patients who reach these late stages it's often irreversible and it leads to death. So that's why early diagnosis is the most important factor in survival. All right, so just a question for everyone. What is a classic and worrisome presenting symptom in children with TB meningitis? Okay, so most people have answered C, isolated vomiting with no other GI symptoms. That is the correct answer, and I think so. This is a clinical pearl that we want to make sure that everyone gets stuck in their head, is that if you have a child who presents with isolated vomiting, then you need to think about TB meningitis in the differential diagnosis. All right. So what are the classic findings of TB meningitis? Well, once TB meningitis is suspected, we need to sample the CSF as part of the diagnostic workup. It should be sent for cell count with differential protein and glucose levels. The classic CSF findings of TB meningitis are low glucose levels with less than 45 milligrams per deciliter, and that we see that in about 80% of the cases. We also see high protein levels ranging from 100 to 500 milligrams per deciliter in most patients, but patients with subarachnoid block can have extremely high levels. And then in lymphocytic pleocytosis, we also see a lymphocytic pleocytosis with with between 100 and 500 cells per microliter. But I should note that these CSF findings are really not specific for TB meningitis, and they can be seen in other conditions, including non-MTB, bacterial meningitis, fungal meningitis, carcinomatous meningitis, and subarachnoid hemorrhage. So for all patients with suspected TBM, we should send CSF samples to be examined by ZN staining for AFB, gram staining for bacteria, India ink preparations for fungi, and antigen testing for Cryptococcus neoformans. In non-MTB bacterial meningitis, so in just garden variety bacterial meningitis, about 60 to 90% of the gram stains are positive, so you can identify the causative organism in most cases. But in contrast, AFB staining has very low sensitivity in cases of TB meningitis, usually below 20%. It's been shown that if you analyze larger sample volumes, up to 7 milliliters of CSF, and if you increase the time that you look for AFB in the slides, so up to 30 minutes, it increases the diagnostic yield. But in reality, most clinical laboratories don't have the time to perform a prolonged examination on each slide. And it's not really clear if larger sample volumes, like up to 7 milliliters of CSF, can be collected in children who have much lower overall CSF volumes compared to adults. Liquid culture methods, when available, have the highest sensitivity for MTB isolation. The results often take weeks to months to be delivered, especially for conventional DST. So it's really not feasible to rule in or rule out TB meningitis because of these delays. Additionally, it requires robust laboratory facilities, so the technology is not available everywhere. So the rapid automated nucleic acid amplification test, known as Xpert, represents a potential important advance in the diagnosis of TB meningitis. As you all know, it's a closed cartridge system approved by the WHO for the use of for use in the diagnosis of pulmonary TB. It detects the presence of MTB as well as rifampin resistance, and it can be used as a surrogate marker for MDR-TB. There has been some work looking at its performance in extrapulmonary samples, but there are really only 2 recent papers that have specifically focused on the use of CSF specimens to diagnose TB meningitis. Both of these studies were performed in adults, so everything that I say next needs to be taken with that caveat in mind. In both studies, the sensitivity of Xpert was around 60%. The first study was a prospective trial from South Africa that reported the sensitivity of about, as I said, 67% and a specificity of 94%, and they looked at 54 HIV-infected patients with definite TB meningitis and 65 patients with non-TB meningitis. The second study was from Vietnam, and in that study, they reported a sensitivity of 72% and a specificity of 95% in comparing 151 cases of TB with 191 cases of not TB. So here is here's a figure from that study from Vietnam, and this one shows the sensitivity of Xpert compared to other diagnostic tests. So you'll note here that the sensitivity of Xpert is about 60% in all patients, but it's dwarfed by this amazingly high sensitivity of smear. The reason for this high sensitivity in smear was because the study used a research lab, or this is what the authors state, that the study used a research lab to perform the smears where the technologists were highly trained and each slide was examined for 30 minutes. And as I previously mentioned, these methods of prolonged smear examination are probably not possible in clinical labs. So the take-home message here is I think that in clinical settings, smear diagnosis is very operator dependent, and Xpert may be more useful because it's equally rapid, but it's minimally operator dependent. It can be done under program conditions, and it has the sensitivity of the test is greater than what most programs would find with smear. All right. So There was also a meta-analysis of Xpert's performance in extrapulmonary TB that looked at over 4,000 samples. Only a small proportion of them were CSF. And here, the investigators determined the diagnostic accuracy of Xpert compared to culture and composite reference standards. And so pooled data from this meta-analysis showed, again, moderate sensitivity for the detection of TB meningitis of about 60%. That was equivalent to the lymph node aspirates, but much better than pleural fluid. So I think that this study, in addition to the previous studies, suggests that there is a definite role for gene Xpert in the diagnosis of TB from CSF. While it doesn't reach the sensitivity of culture, it could improve the diagnosis of CSF TB in places where culture or other diagnostic tests are not available, or where a rapid diagnosis of TB is necessary. Which is the case in TB meningitis. I should point out, though, that there are some downsides to Xpert that need to be noted. First, and most importantly, a negative Xpert, just like a negative smear or a negative culture, doesn't rule out TB. Second, there are rare false positive results for rifampin resistance, so there is a consequence of mistakenly treating patients who have rifampin-susceptible TB meningitis with weak second-line regimens, and that would be a problem. So I would recommend that if possible, any diagnosis of rifampin-resistant TB meningitis by Xpert be correlated with clinical suspicion of drug-resistant disease, and also, where possible, confirmed by a second rapid test such as a line probe assay. But these issues aside, I think my personal opinion is that it won't be long before Xpert is the preferred initial test in diagnosing TB meningitis. So let's talk about some of the complications of TB meningitis. So as TB meningitis advances, the patients develop a range of CNS complications. They often stem from an underlying increase in intracranial pressure. The CSF is produced in the choroid plexus, and so here, in the choroid plexus, CSF is produced, and in the lateral third and fourth ventricles, and it circulates through the subarachnoid space between the arachnoid matter and the pia mater. And so communicating hydrocephalus then arises because the inflammatory process of TBM sort of extends into the base of the brain, and the pus fills the basilar cisterns and impedes CSF circulation and resorption, raising the intracranial pressure. So because of this, complications are common. Patients with advanced disease often present with multiple cranial nerve palsies involving cranial nerves 3, 6, and 7, as well as hemiparesis, paraparesis, and seizures. Hydrocephalus occurs in about 80% of patients with TB meningitis, more commonly in children than in adults. Stroke is common, with infarcts occurring because of vasculitis that affects the vessels of the circle of Willis and the branches of the middle cerebral and the vertebro-basilar circulation. And then we also see hyponatremia. It's common in children. It's usually because of SIADH or cerebral salt wasting, and it is associated with worse outcomes. We see tuberculomas or TB mass lesions. They can occur in isolation or in association with meningitis. They're often silent, but they can cause focal seizures in otherwise normal children, so that's another clinical pearl to remember. And they can obstruct CSF pathways that can cause an increase in intracranial pressure. And then with HIV patients who are receiving TB meningitis, there's this risk for clinical deterioration after initiation of ART due to immune reconstitution. And so, we can see worsening or new clinical signs or symptoms of TB meningitis. So, with these complications in mind, then we can assess a grade of severity to the presentations of TB meningitis. I'm not going to read through the grades. You can read them there. But I just want to say that even though we can come up with a standard definition of disease, there's really no national or international guidelines for the diagnosis and treatment of CNS TB in children. There's also, there's there's no institution specific approaches to the management have really been shown to be superior to another. So there's really little consensus or standardization about the treatment, across different centers. It's one thing I would say that's pretty confidently, I can say pretty confidently, is that head imaging is helpful. It's in the diagnosis of pediatric TB. CT, head CT is the most often used in resource-limited settings. About a third of children who have stage 1 disease have normal findings on CT scan. Most common findings are meningeal enhancement, hydrocephalus, basal exudates. Those are all highly suggestive of meningitis, TB meningitis. The MRI, where available, is superior to CT because it's more sensitive for detecting these basal enhancements. This particular image is an axial T1 weighted head MRI of a 1-year-old child with suspected TBM, and it demonstrates these thick basal thick enhancement of the basal leptomeninges, ventriculomegaly, and basal exudates. So MRI can also reveal subtle infarcts, and with angiography you can see some vascular involvement. So there are definitely some low-cost interventions to manage the complications of pediatric TB meningitis. So correction of symptomatic hyponatremia is recommended using a slow infusion of hypertonic saline. Fluid restriction is not recommended for these situations because it can cause hypovolemia and decrease cerebral perfusion. Acetazolamide and furosemide can reduce CSF production by blocking carbonic anhydrase activity and reducing ICP. So that can lead to normalization of intracranial pressure. Elevating the head of the bed is also important. Systemic steroids can be used to decrease vascular inflammation and cerebral edema that underlies many of the complications of TBM. I would argue that all patients with TBM should be, including children, should be treated with systemic steroids. Prednisone is sort of the treatment of choice, 2 to 4 milligrams a day for the first month, then weaning it. So tuberculomas are often resistant to anti-TB treatment, and they can require additional interventions. Thalidomide has been shown to be effective in treating tuberculomas. It's a strong inhibitor of TNF-alpha, which contributes to TB abscess formation. So that should also be in our armamentarium when we manage these patients. Patients who have hydrocephalus that's refractory to medical management may require surgical decompression of the ventricular system. So, in patients with stage 2 disease, we can try serial lumbar puncture and steroid therapy, but I would say that surgical intervention shouldn't be delayed in patients with coma if you have progressive neurologic impairment. All right, so that's I think some of the most common complications of TB meningitis. I would say that these are common in both drug-susceptible and drug-resistant disease, but they need to be managed aggressively in both cases. So let's now switch to another case that focuses on the regimen choice in the settings of possible drug-resistant pediatric TB meningitis. I'm going to turn the microphone back to Dr. Gegia.
Okay. Because we have really run out of time, I will present that case very briefly. So here is another example from the clinical setting, and this is a 15-year-old girl who, unlike the first case, has no contact with active DR-TB. So she developed fever, fatigue, and severe persistent headaches over the 1-week period. So her neurologic exam showed the stiff neck, positive kerning symptoms, and her chest X-ray was checked, but it was normal. So here is the basic lab examination result, and her CSF was sent for microscopy and culture. And again, we see that smear was negative, and the culture result also appeared negative. So this is, I would say, the more common when we don't have culture results. So it's like a more frequent case than the first one that
Sure. Yep, this is Jennifer, so I'll take over. Hello, everyone. So the CSF examination on the patient showed an elevated white count and an elevated protein, but as in the case of most patients, the microscopy and culture was negative. This patient was empirically started on first-line anti-TB therapy with a classic HREZ, but she did not improve, and her clinical picture concerned the physicians for possibility of MDR-TB. She was hospitalized and her treatment regimen was modified to include both first-line and second-line therapy for possible MDR-TB. I'm going to just skip the question. It was regarding how long she should be on the first-line drugs in the absence of smear and culture confirmation, and the answer is if you're treating for both pan-susceptible and possibly resistant TB, the first-line drug should be administered for 12 months, as is recommended for the management of pan-susceptible TB meningitis. The patient, her temperature normalized, she was discharged from the hospital, and she completed 20 months of treatment. So the point we wanted to bring up in this case is really the importance of contact tracing, and really what will help you make a decision about whether to empirically initiate MDR-TB therapy, which is actually a big deal in children, is whether or not they've been in contact with someone who has MDR-TB. Now, a lot of times if you ask the parent or the caregivers that has this child had a contact with someone with MDR-TB, they may tell you no. They may not be aware that someone was diagnosed with MDR-TB. That may be very stigmatizing to the family. And so when you do your contact tracing, it's really important to ask, has anyone been treated, for lung problems? Have they received injections, et cetera? A lot of families will just tell you no, and this is really the key. The Xpert test is important not only for helping us diagnose TB meningitis, but it does give us a rifampin result within a matter of hours. So again, this is an advantage for Xpert over smear. So we're also going to skip the next question. So in terms of empiric therapy, it is really important. I think MDR-TB meningitis really emphasizes many of the challenges we face in MDR-TB in children in general, which is difficult to diagnose. You end up making a clinical decision whether or not to start these children on, a 6 to 7 drug regimen for 18 to 24 months with a daily injection, et cetera. With TB meningitis, it's kind of the time frame in which we have to make these decisions is so much shorter that it really pushes us to make them quickly so that the child doesn't end up dead or with severe neurologic complications. So really, for me, the biggest risk factors, do they have a contact in the household with possible MDR-TB, whether it's confirmed, someone who's failing treatment in the household, someone who died while on treatment, et cetera. So just to keep that in mind. We're going to get to the questions. I promised there were several questions about dosing and CNS penetration. Really, the dosing should be the same as for children with MDR-TB in other sites, although I will point out we're lacking PK information on that, and that controlled trials to determine the optimal drug regimens have not really been conducted. People are asking about CNS penetration. There's really not any good data on the second-line drugs, but in TB meningitis, the meninges are inflamed, and so we assume that there's better CNS penetration of the drugs into the central nervous system than there would be in a setting of non-inflamed meninges. So we really recommend that even though a drug may classically not have CNS penetration, that it be used in the treatment of drug-resistant TB meningitis because it may penetrate as well. So just to quickly answer some of the other questions, it is recommended by the WHO that all children with TB meningitis, and that includes DR-TB meningitis, be put on steroids. There was a question about can you use prothionamide in the setting of ethionamide resistance, and the answer is no. These drugs should really be considered the same drug, and there's 100% cross-resistance between the two. In terms of the earlier study that Dylan was speaking about in terms of the CSF finding, they did centrifuge those samples and they were examined for 30 minutes because that's felt to improve the sensitivity if you look at a slide in a much more systematic fashion. There is definitely a place for neurosurgery in TB tuberculoma. However, it depends on the size of the tuberculoma, the location, and the quality of your neurosurgical program. Thalidomide does not interact with the other anti-TB drugs. we can certainly make ourselves available to go back and answer any specific questions about the cases. I know we went through them relatively quickly. So if there is INH monoresistance in the index or the relative case, it would be appropriate to not give the child isoniazid, depending on the age of the child and the likelihood that the child may have been exposed outside of the home. Some studies and some case reports have used VP shunts in patients with TB meningitis, and I think that early shunt placement can be a benefit to children with MDR-TB meningitis. However, again, it depends on your access to neurosurgery and the quality of the post-operative or post-drain placement monitoring. These children can be at risk for infections in the CNS that come through the extraventricular drain, so it's important to be aware of that. So just to quickly summarize what a wonderful presentation we got from Dylan and from Medea, and I really thank them. We know that pediatric DRTB is an unrecognized problem, and this is even more so for pediatric DRTB of the central nervous system. You know, based on the numbers we looked at, we should see over 1,000 cases of DRTB meningitis in children every year, and nobody is seeing those numbers. The largest case series reported is of 8 patients. So it's really unrecognized, underdiagnosed, and points to a lot of the needs we have for pediatric DRTB in general, because we need to diagnose it quickly and start patients on therapy. Poor outcomes are associated with delays in diagnosis. So you need to have a high index of suspicion for meningitis, look for isolated vomiting, headache, fatigue, and decreased play. But it's really the contact history that will be essential in making the decision to start a child on empiric DRTB treatment for possible meningitis. Anyone in the family who has a history of TB that hasn't been cured, that died, that failed, or documented DRTB, this child is someone who should be started on empiric MDR therapy. We know that Xpert can be a great addition. You know, most countries don't have access to culture and don't have the resources to really take a high volume of CSF, centrifuge it down, look at it for 30 minutes per child. And the Xpert can tell you up front if you have MTB present and whether or not it's rifampin resistance, which is really the key in the setting of TB meningitis. Following the same principles of the management of pulmonary MDR-TB in children is key, but you may need additional, you definitely need additional steroids, drainage, placement of an extraventricular drain, and thalidomide may have a possible role if there's tuberculomas in the brain. And again, as we mentioned, the importance of empiric therapy. So I apologize for rushing through at the end there. We always have so much to talk about in these important cases, but I'd really like to thank especially Medea and Dylan for putting together a wonderful case here that illustrates some great teaching points in pediatric DRTB meningitis, and to thank all of you for attending the workshop. If you have specific questions, you can let Evgenia know, and she can put you in email contact with Dylan, Medea, and myself. And I just